Um, and like I mentioned a little bit earlier, latest data from Yale, which is published in 2018, was there was no cognitive decline from prolonged use of ketamine, and this was IV ketamine that they were doing. They were doing only 4 infusions for this for the initial responsiveness, and we have de- uh, deferred to 6 infusions based on the National Institutes of Mental Health studies of a 92% success rate of people who are going to respond within that time. So this is a patient with acute suicidality. You can see that they went from severe, no joke. I mean, after taking care of tens of thousands of patients in the emergency departments throughout the Commonwealth, um, you can see that, I mean, this guy, you walked in the room and you knew he had a date, he had methods, he had a plan, and was very scary, to be quite honest with you. But I mean, after his second infusion, you can see that he's gotten kind of progressively better. There's other issues with this patient specifically with some substance abuse issues, substance abuse issues, as well as some situational factors that have kept him from that depression-free range. But I'm very thrilled to um, let you know that he has been treating with us as recently as this month, and this will mean 2 years of him treating with us, and that he has not been suicidal for any of those 2 years after the initial round of 6 infusions. So we're very pleased with that. This 20 years, 53-year-old lady comes in, literally only had 1 infusion, was exhausted for a week to 10 days, but you can see got progressively better. We stopped following her several months later. But to this day, I believe she has been doing fine without any issues. This is definitely an atypical response. Normally, it does take 4 to 6 infusions for people to have this level of prolonged change. But obviously, thrilled that this lady did much better. This is also working on postpartum depression. It's and not an FDA-approved usage, although there is a new 60-hour infusion that we will get to for treating depression. But you can see for postpartum depression, there was 1 rescue infusion, followed by 6 other infusions. We got her to essentially a depression-free range. You can see the 1 dip between the initial series of 6, which the vertical lines are infusions. And you can see 1 dip back into the moderate range when the patient was questioned about the reason for the dip. She explained it as mother-in-law related issues. So unfortunately, ketamine does not take care of mother-in-law related issues, at least not to the best of my knowledge. There's another patient that came here, a younger male, 35, 37, 15 years of pretty severe chronic depression. And truthfully, we had to have an uncomfortable conversation at number 6, basically saying that I didn't think he responded. He called, 6 weeks later and asked for a booster infusion. And with the booster infusion, I said, well, why do you need a booster infusion? This didn't work. And he's like, after the 6th infusion, I just got better. I've stopped taking all my other meds. I'm just taking vitamins. He's now successfully back in school. He sees us every 4 to 6 months for an infusion. But you can see that, from very severe depression, this is using a PHQ-9. I mean, he essentially went to the 3 level from 27, 26 in a matter of weeks. So it's pretty impressive. PTSD, obviously much more complicated. We can probably put some other patients in this to kind of show you. But you can see, especially on the upper chart, which is our daily text message 1 to 8, the patient got from basically a very constant level of 1 to a level of 8 pretty consistently. He had some other situational factors, that obviously prevented him from being quite as successful as we would have hoped. But the change was pretty dramatic. He started going out with friends. He started interacting with people more. He started having more success with how he interacts and goes out with friends, etc. So that was a pretty impressive change as well. For non-responders, like I mentioned, there are approximately 1 in 4 people who do not respond to ketamine. That could be for a variety of reasons, but the simple version is that they don't respond. You can take a look here, and you can see pretty flat, despite 6 infusions, a pretty flat responsive rate. And that unfortunately happens in about 1 of 4 patients. They just don't respond. Adverse effects. It's not the cleanest medication, and it can cause nausea and sometimes rarely vomiting. We normally treat that with Zofran, Phenergan, scopolamine patches, etc. Anxiety. Some people really do not like the experience of the ketamine, and the anxiety that they get from it is normally controlled with midazolam IV. So 2 milligrams. Some people take as much as 6 or 8 or 10 milligrams over the period of 40 minutes. It really is patient dependent. We haven't had any issues with this suppressing patients' breathing or any issues, and it's pretty much the standard of care for us doing it. Hypertension, you can use beta blockers. Like I mentioned, I pretty much don't treat because the hypotensive elements are normally transient and from catecholamine release in the peripheral nervous system, and can be controlled with beta blockers. But until it gets to a level of 200 millimeters of mercury systolic, I really don't start treating it at that point in time, and I rarely treat the number. Altered mental status with any anesthetic, it's just supportive care and time. There is no reversal agent for ketamine at this point in time. Enuresis, obviously supportive care, and that's normally for longer pain infusions. Rare are ulcerative colitis, ulcerative cystitis, but we're talking about normally ketamine abuse. So you're talking between like 5 to 10 grams a day. To give you an idea, we're treating patients with normally less than 100 milligrams of ketamine on a regular basis per each infusion. So the numbers are just magnitudes higher by the time you have ulcerative cystitis. That being said, it is possible for that to be an issue, and normally a urology referral is indicated. This is the most serious, the laryngeal spasm of the potential side effects. And in a case control analysis, basically needing possible intubation and ICU admission, you're talking a 0.04 to 0.0026% chance. I have not had any of these complications. I've had some patients cough, and I got a little bit concerned, but nobody with laryngospasm that necessitated any intubations. Dr. Glenn Brooks of New York Ketamine in Manhattan has been doing this the longest out about just about everybody at somewhere in the neighborhood of 7 or 8 years. He's treated more than 30,000 patients. He hasn't had any issue either at the dosages that we're using. That being said, obviously with this being a known complication for ketamine, I think it makes a lot of sense to have the patients present. And when I say present, I mean capable people of intubating and taking care of this potential side effect. Unfortunately, it does not seem to have any association with age, dosage, or other clinical factors. There's not patients that we're aware of that have a higher risk for this potential complication. Now, the area that I got in, the reason I got into this, obviously not being formally trained in psychiatry, we do in medicine take care of approximately 20% of our patient population is psychiatric related, including suicidal patients. And I had one patient who came in a beautiful fall morning. She had been depressed for years, quote unquote, and on a beautiful fall morning, for no apparent triggering reason, she went out to her shed and shot herself in the head. And I had the very unfortunate and unenviable position of having to get her husband uh, to consider donating her organs in about 90 seconds. And I was not successful, unfortunately. And she left behind, I believe, an 8 and a 10-year-old son and daughter. So this impact is very real. But when you take a look at ketamine for suicidal ideation, and we're talking a single dose here, not 6 doses, but a single dose, you can see the absolute profound change and decrease of suicidal ideation. And in combination with this data, other data from Lori Calabrese, who's a psychiatrist in Connecticut, who recently published a study basically saying that it took approximately 3.1 sessions on average. So you're talking 3 sessions of 0.75 milligrams per kilogram to take care of suicidal patients and have suicidal symptoms resolve in an outpatient setting. Obviously, this data is from 2010, 2009, but you can kind of see that for a decade, this has been a pretty substantive change, potentially in suicidal patients. And when you talk about the change, it's now been FDA approved, so it's kind of create an interesting and hopefully very change-worthy element of how we treat and approach suicidal patients. The best proof of concept study that I saw from 2017, December of 2017, basically took 80 patients, 40 in a control group with midazolam and 40 other patients in the ketamine group. And you can see that they had a number needed to treat of 4 for suicidal patients. I mean, this is really impressive. And that's just with one infusion. While the study wasn't perfect and only did 1 infusion, they did have some suicides later in the course of their ketamine controlled. But the interesting thing about what they did is they used, with the midazolam control, they went back a week later with the midazolam control and they gave them ketamine, and basically saw a statistically significant difference in this. And you can see these single dosages now, and the ketamine control group on the upper left of your screen goes down pretty significantly from 3 to less than 1.5 versus the control. And you can basically kind of take a look and see kind of how this all played out. When this is being done, I think a course of 6 is definitively indicated at this point in time. Some of the recent studies from Yale indicated that they only gave 4 infusions to see if somebody was responsive. And with this is in a patient population of treatment-resistant depression, defined as failing at least 2 different infusions, 2 different trials of oral antidepressant medications. So to give you an idea of the prevalence of ketamine clinics, to see kind of how they've been, implemented across the nation. So this data is from 2015. You can see, 15 to 20 different ketamine treatment facilities throughout the nation. So a smattering in some major metropolitan areas. This, of course, is a little bit of an older slide, I believe published in 2016, but it basically can kind of give you an idea of the cumulative number of providers. So in 2016, this was as they could quantify it, between 50 and 60 different physicians and or CRNAs or psychiatrists who were administering ketamine in an off-label outpatient setting. Those numbers have increased pretty dramatically since the publishing of that study. Those clinics, this is the 2018 data from the American Society of Ketamine Physicians, and these are only the directory listing of the group, the Society of Ketamine Physicians, that are doing this. You can see that in 2018, this has gone up between probably 150 to 200. And when you come to the latest data, between 250 and 300 different infusion centers throughout the nation. Now, keep in mind, this is still an off-label usage of ketamine, even though S-ketamine has been approved for both the treatment of suicidal ideation now as of the 31st of July, as well as in 2019 for the treatment of major depressive disorder. But you can see there that obviously the number of infusion centers is growing significantly, and this is probably accounts for a third to a half of actual facilities. So not each one is going to be incorporated in this specific map or representation. Before we get to the pipeline, I just wanted to talk to you one quick second about the difference between Spravato, because we have a couple of minutes, and S-ketamine nasal spray versus ketamine infusions, which is the generic. A couple things to note. The average infusion for the average infusion that we've been doing is somewhere in the neighborhood of 75 milligrams to 100 milligrams per patient. And that's done over 40 minutes. We started at dosage of 0.5 milligrams per kilogram, and then we titrate to effective partial dissociation. We do 6 infusions with booster infusions on an as-needed basis. Spravato works a little bit differently. Its absorption is between 18 and 48% versus almost 99% for the ketamine infusions. The cost is also very high and not necessarily always covered by insurance for the Spravato, unfortunately. They do 2 infusions per week for the first 4 weeks, followed by basically the weekly phase for the next 8 weeks of 1 treatment per week. The FDA also requires that we watch the patient in office for 2 hours after their last nasal spray, versus the ketamine infusion. What we do in the standard that we do is basically approximately 90 minutes start to finish versus 2.5 hours. So you're talking a very different both efficacy as well as bioavailability difference in the medication. Our recommendation, or my recommendation, would be to stick with a ketamine infusion just because of the bioavailability, the control element of things. I mean, and you're probably talking, even though the data has seemed murky at best from Spravato and the efficacy thereof, I think what you're going to find is you're going to find that when you do the IV infusions, getting between 70 and 75% response rate is really amazing, versus probably closer to 40 or 50% for the Spravato. And the cost difference is very significant. For us, the cost of doing 6 infusions is approximately $3,000 versus the Spravato. Just the medication alone can cost you over $10,000 for the first round of 8 by the time you put in the office time. So it's really a significant difference.